So at this time, I would like to introduce our 13th Charles J. Tegtmeyer lecturer, Dr. Victoria Marx, introduced to us. Before we get started on our lecture, I want to tell you a little bit about Vicki. Yeah, you can sit down if you want. Vicki received her MD from and did her residency at the Ohio State University. She graduated medical school and was elected to Alpha Omega Alpha. And she was the chief resident of Ohio State. And that's where I first met Vicki at the AQCR squared meeting. I think we decided she was in Hartford, Connecticut, where I heard her laugh on the bus and then got to meet her. Since then, we became friends. After finishing her residency at Ohio State, she went to Washington University Medical Institution, where she did an abdominal fellowship and an interventional fellowship, and then stayed on faculty at WashU in interventional radiology until she was recruited to go to University of Michigan. At University of Michigan, she was appointed Chief of Vascular and Interventional Radiology. As a perspective, that program probably is about twice the size of our interventional radiology program. After a decade at University of Michigan, she and her husband, who is a plastic surgeon and burn specialist, were both recruited to University of Southern California, where she became Director of Education, becoming the Vice Chair of Education and the Residency Program Director, a role that she served 15 plus years. And is now serving in that role now. In that role, she's always been a very big champion of IR and IR education. She is currently the program director at University of Southern California, where she has been a professor on faculty there for 20 years. A fellow of the SIR and the American College of Radiology, she's been recognized on many top doctors lists across the United States and has given 200 invited presentations at national and international meetings. A member of the American Board of Radiology Board of Trustees, a longtime examiner, question writer, volunteer for the ABR, and receiving a Lifetime Achievement Award from the ABR. She has served as the chair of the Association of Program Directors in Radiology and is the chair of the Radiology Residency Review Committee. This is a very critically important position, a very influential position. A model of servant leadership with a signature laugh that makes people around her feel happier and smile. Dr. Marx has served as the chair of the SIR annual scientific meeting. As a past president of the SIR, and for her significant contributions to the specialty of IR, she was awarded the SIR Gold Medal last year in Boston, one of the highest achievements in the field of interventional radiology. So to provide you a little background why we established this lectureship, Charles J. Tegtmeyer, known as Tunk around here, started really what was called special procedures here in 1973 when he came here from Boston. Dr. Tegtmeyer was a surgeon at heart. He'd done 3 years of surgery before he went into interventional radiology, and he established a school of radiology technology specifically for what is now interventional radiology. In 1973, as Anita Bell told me, graduating his first class in 1974. He was well known for his work with renal artery interventions. He was, here's an example. Back in the good old days, when we were using 8 French balloon catheters that had to go through 8 French sheaths in the groin, they were stiff as heck and had terrible tapers. He developed a balloon on a guide wire that could go through a 7 French guide sheath so that you can actually inject and check at the same time while you did that procedure. It was called the Tegtmeyer. He was an avid fisherman. He loved fishing. He in fact sold fishing equipment from his basement to make money on a sideline. But the story goes that he went in 1978 to spend some time with Andreas Grunzig in Switzerland to learn about angioplasty balloons. He went there with a suitcase full of fishing equipment. The guy that handmade the balloons, because this was not made by industry, made a bunch of balloons it turned out the guy making the balloon, a guy by the name of Remy Schneider, was a fancier of fly fishing. So Tom traded all his fly fishing equipment for a suitcase full of balloons, brought them back here, did the first iliac angioplasty here at UVA in 1977. Okay, he was an avid teacher. This is here with Lori Bettner wearing the white scrub. She was our first female IR fellow at that time. And then a tech student. He always was a stickler about perfect films and procedures. He felt that he was like Superman sometimes. And I remember him telling Fritz and me, it's tough to always have to walk on water. We now have his lead frame in the IR reading room in honor of Tunk. He was a very competitive person. And this is when I was here as a first-year faculty member. Tunk is the one standing in the middle with a star. Bain Selby is to his right, and I'm to Bain's right. Next to Tegtmeyer is Andy Reichsnyder, who was a scratch golfer and went to University of Texas on a golf scholarship, so he's very good. And you can see Fritz in the middle, standing next to Mike Sorosi. Those were our three fellows. So we started playing golf. We knew Andy was a great golfer, but you could get into his head. So Tunk would drive his golf cart over Andy's ball before Andy could find his ball. And Andy would come up and go, what's up with my ball? I'm not gonna be able to hit out. And so he just got in Andy's head. But for the first 9 holes, the attendings were playing the fellows, we were losing, and it started pouring rain. Started lightning, they started sounding the horns to get in off the course because it was dangerous. Tegtmeyer would not let us leave until the attendings got up. We actually got up and tied, but he did not want to walk off the course as a loser. And so there we are, after he finally let us go. We're soaked to the, and finally they had to drag us off because they said, you know, it's dangerous to be out there when there's lightning, but he would not let us get off the course until we tied it up because he was not going to lose to the fellows. Dr. Tegtmeyer was very much a stickler in many different ways. At a time when we were not supposed to be smoking in the hospital, he smoked that pipe in his office. And his tactic was, if he wanted to have a difficult conversation with you, he would go to his office, smoke his pipe for 30 minutes, you'd be full of smoke, and then he'd ask you to come over and talk to him. Your eyes would be watering when you walked in there, and he'd talk to you, and if he wanted something from you, he just kept pushing you to say, okay, and you go out. After I got to know him a little better, he told me he did that on purpose. He knew exactly what he was doing. He was one of those people that you either really disliked or you really liked. He was very charismatic. He'd walk into a room, he'd light up the room. He always had a Diet Coke in his hand. All right. And he always had that pipe in his mouth. He was always twirling his mustache. Unfortunately, he passed away at a young age of 56, and we established this lectureship in his honor 13 years ago. So at this time, it gives me a great pleasure to introduce Dr. Victoria Marx as our 13th Charles A. Tegtmeyer lecturer. And please know, Dr. Tegtmeyer is happy that you are the 13th lecturer, and he'll be watching. Thank you.
Okay, well, thank you for that kind introduction, and I really enjoy getting to know Dr. Tegtmeyer a little better. I did see him when I was a radiology resident. I went to a early SIR meeting when I was a resident in Miami, I think, and it was in a hotel, so it was before we were doing convention centers, and I remember being just mesmerized by him giving a talk showing all these renal artery angioplasties he did when like nobody else in the country was doing it. It's a memory that stuck with me a long time. I'm honored to be here and a little intimidated, but there you go. So let's see if I can do this. There's so many pictures. Okay.
Is your mic on, please?
Oh, did I not turn it on? Oh, that's a problem. Did the Zoom people hear me? Anything I said? Hi, Zoom.
They're not complaining, so I think.
Okay. Okay.
Yeah, we can hear.
So I'm here, I feel like I'm here to describe what I have seen over the course of my career, which has been the evolution of a specialty, which means that I'm an early evolutionary specimen. And I'm honored to be here on this named lecture. And I hope that you enjoy my presentation. And I'm sure at some point during it, I will laugh and you'll know what he's talking about. So anyway, interventional radiology, the evolution of a specialty. I do have some conflict of interest in that I am a member of the ABR Board of Trustees, and I am a member of the Radiology RRC of the ACGME. They don't give me any money, but they have points of view. And I am here as an individual. I am not here with an ABR point of view or an RRC point of view. I'm here as a stakeholder who values the specialty of interventional radiology. And please don't tell anybody on the board or the RRC what I'm saying. So anyway, so where did we start? It was a long time ago in a galaxy far away when Alan and I were both very young. And it really started in the 1950s and 60s, I think. And I'd say a key early development was the Seldinger technique. Sven Seldinger was a radiologist in, I forget if it was Sweden or Norway, Sweden. And he, at one point, said he had a severe attack of common sense, which led to the development of, people used to put a big needle in an artery, and it had to be a really big needle because then they put a plastic tube through it, right? So he said, well, put the needle in, put a wire in, take the needle out, put a plastic tube in, take the wire out, and then you made a small hole. And it was, and he like never did any other investigation again. And he, in Sweden, when he was getting his radiology degree, he had to like write a dissertation. And so his dissertation proposal was on this development of the Seldinger technique, which really revolutionized arterial access for the world. But his supervisors didn't accept it. They didn't think it was, they thought it was kind of a stupid, unnecessary idea. And so he had to propose another dissertation. So he developed percutaneous transhepatic cholangiography using the same Seldinger technique, and they accepted that. Anyway, so during the 50s and 60s, in not all just because of it, but other things that happened that allowed arteriography basically to develop was the development of arterial catheters and guide wires and progress in imaging equipment. So the first thing was to develop imaging tensifiers so you could actually see what you were doing without having to put glasses on and stare at a green screen. And you guys don't even, I mean, look it up, so Google it sometime. What do they call those things? I don't even know.
Glasses and green screen.
Yeah, yeah. Then the idea of rapid filming so that you could keep up with arterial flow. And these were film changers where you had a big piece of film, and then the technologists had to develop all that film, right? And it was very slow. And then they also developed power injectors. But when I first was a resident, doing an arteriogram took hours. And because you do a set of pictures, then the technologists had to go develop them. And then you had to make hand subtractions to see. And all that time, what were the interventional radiologists doing? While the technologist work was going on, the interventional radiologists were smoking. So the development of DSA in the 70s is what made interventional radiologists go smoking. Anyway, so that was the 50s and 60s. And also in the 60s, because of all those developments, we developed diagnostic arteriography. And here's one of the early textbooks. That was, who wrote that? Reuter, Redmond, and Cho. And I worked with Dr. Cho at University of Michigan. But the idea was that you could diagnose cancers, basically. And so there were chapters and chapters in textbooks about arterial patterns of different types of tumors and how a spoke wheel in the liver meant one thing, and disorganized, they had all kinds of words that we don't use anymore. But that was how you would, if somebody had hematuria and it wasn't stones and they thought you might have a renal cancer, you got an arteriogram. And then interventional radiologists would stand there and smoke and try to decide if you had cancer or not. So the other thing that happened, because before we developed devices, they figured out that you could put medications through these angiographic catheters. So pharmacoangiography became a thing. And the first kind of minimally invasive interventional technique to treat GI bleeding was vasopressin infusions through an arterial catheter. And you would titrate the dose of vasopressin by how much ischemic abdominal pain the patient had. That was a great advance. So angioplasty was the first practice in 1964, the Dotter technique, where he put, increasingly, caught on something, increasingly bigger size dilators through stenosis. So the idea of angioplasty and treatment of atherosclerosis and vascular stenoses came into being in the early 60s. And Margulis in 1967 made the first mention of the words interventional radiology in a book or an article. And here's an interesting quote. This is 1968. This is Charles Dotter. If we don't assume clinical responsibility for our patients, we will face forfeiture of our territorial rights based solely on imaging equipment others can obtain and skills others can learn. And people heard it, but didn't really pay much attention. And the reason I think that we didn't pay much attention was because we weren't hungry yet, right? There was no real threat to the territory. So in the 1970s, we saw a big change in both imaging modalities. So the big ones that came on were ultrasound that looked like you could tell what you were looking at, as opposed to the old kind of ultrasound where you couldn't tell what you were looking at, and CT. CT was a huge advance. You know how EMI got the money to develop the first CT? The Beatles. Yeah, they were a music company that owned the Beatles, basically. That's how they got the money. The other thing that happened in the 70s was this was the first real splurge of device development, of devices that you could put in the body through small holes, basically. So there was angioplasty balloons, as Alan already mentioned, embolization coils, geointercal coils, I think first came into being in the early 70s. Drainage catheters, Cope loop drains came into being in the 70s, and we're still using that technology. Nobody's thought of anything better. And IVC filters, they were not initially designed to be percutaneous, but I put in the first percutaneous IVC filter at Ohio State with the head angiographer at the time, and we basically put in a 24 French sheath that had no valve at the back end. So when you put in a 24 French sheath and there's no valve at the back end, and you take the dilator out to then put the filter in, there's audibles leaving. It will splash on the floor. So that was a great thing. The big device development that helped that problem was they put a pinch valve. They put basically like silicone tubing on the back end of the big sheath that you could then manually pinch shut. That was a big device. I'm sure it has a patent that made somebody some money. And so in the 1970s, I also wanted to mention Dr. Tegtmeyer because he had a significant impact on this procedural and device development. He joined the UVA faculty in 1973, became a full professor in 5 years, studied PTA with Grunsig, and traded his fishing rods for angioplasty balloons. He was really a PTA pioneer in the US, and like Alan said, he did the first renal PTA in the US, the first iliac occlusion PTA in the US, and named and developed, was the first person to have the idea to do kissing balloons for bifurcation lesions. And I think a lasting legacy is the fact that he developed the first school for IR technology education that really established IR technologists as a separate group and gave them a better education. So I think he's had a big impact. I'm not sure if he's in this picture. As groups of people start doing things, the natural development of a specialty is you form a club so that you can talk to other people who are interested in what you're doing. So the Society of Cardiovascular Radiology, remember, it was all arteriography and diagnostic arteriography mainly that brought all these people together, was formed in 1973. And their first meeting was in 1975. I don't know if Tegg was there, was he? Yeah. And I couldn't figure out if he was in this picture or not. This is really a fashion statement, this picture, if you look very closely. There clearly aren't any women in the society yet. There were 47 members and 177 people came to this meeting that I think was in Puerto Rico, right? No, I forget. It was in the Caribbean someplace, I think. And then what happened in the 1980s? So you've got further progression of technology, like a DSA came into being, and that was a huge advance. Microcatheter systems were first invented in the 1980s. Refinements, the smaller balloon catheters and PTA. IVC filters people started doing work on making them smaller, the introducer systems. Vascular stents were developed. Palmaz and wall stents were the first big ones, the balloon expandable, the self-expanding. Thrombolysis became a big deal. So that was developed, Bookstein, I think, in University of San Diego, UCSD. Needle biopsies first came into being in the 1980s. Now think about it, before then any kind of biopsy went to surgery. And then the percutaneous abscess drain, the Van Steinenberg sump was developed. My favorite development in the 1980s was the wire. I think that was a great advance. And there were some things that happened in the 1980s that have since disappeared. There is no interventional radiologist in the world who is sad that Viagra came online so that we didn't have to do corporate cavernosography anymore for erectile dysfunction. That was a bad period. I have one funny story. All right. So I'm doing this corporate cavernosogram. And I forget what the story was, erectile dysfunction. And the next day, I come into work, and in my office is a bouquet of flowers, right? And do you know what a bird of paradise flower is? So it was a very modernistic, there were twigs that were swirling around, and then there was a big, tall bird of paradise sticking up out of the middle of it. And I had to just leave it in my office. I could not take it home and explain it to my husband. So in the 1980s, I think you mentioned this stuff, but Tegtmeyer, there's the low profile, well, let's see if I can do this. Oh, there's a low profile balloon he developed, right? And so that's one of his contributions in the 1980s. He published like 50 papers in the 1980s. It's crazy. See if I can do this again. So here's one of his big papers on FND, angioplasty for FND. He talked about embolic control of iatrogenic hemophilia. So that was a new thing, the embolism. And then he developed a way to break up Steinstrasse after ESWL for people who they were doing ESWL on stones that later people figured out were too big, and they get this whole big cast of stone fragments in their ureters. He figured out a way to clear them. So he was an incredibly creative guy. And those were all things that he published in the 1980s. In 1983, the Society of Cardiovascular Radiology changed its name because look at what's all going on. They aren't just diagnostic radiologists anymore, right? They're developing an identity as an interventionalist. So they changed the name of the society to the Society of Cardiovascular and Interventional Radiology, and he was the president a couple of years later. And then here's a demonstration of a bad idea. So if your society name is so long, you have to abbreviate it on the logo, then there's a problem with the society name. And that haunted us for a long time, as far as identity goes. So SCVIR now is kind of new, a society that has a growing group of people who are sharing a vision of developing a specialty. A lot of things happen. So in 1986, the members of the club said, well, we're going to open up membership to anyone practicing interventional radiology, and the membership exploded to 500, like right away. And they also added advocacy so talking to the government and insurers and economics to the mission of the society, which previously had been science and education only. So these are all steps that most specialties go through as they establish the reality of their existence in the world and the extent and impact of their domain. They made the decision in 1986 to pursue becoming a primary specialty. So people had a vision a long time ago, and it takes a long time you have to be an elephant leaning for a long time to make big changes like this. In 1989, they developed IR billing codes. So, making unique billing codes that were described what we do, because there was no billing codes to describe what we do before. The foundation was established. I think that was I think Ernie Ring was a big pioneer of that. The first standards of practice was written. So when you are establishing a specialty, you want to be able to tell the world how that specialty should be practiced. What is a standard of care? So Alan led developing standards of practice for how an interventional radiology suite should be staffed, right? And so the idea is when you have papers like that, then other practitioners go to their hospitals and say, look, there's a standard, there's a best practice for how we should do this. So that's part of the establishment of a unique specialty. And then they developed a due structure. So in order to do work, societies have to make money, right? So now we're in the late 1980s, and here's another quote. Developing a successful interventional practice is analogous to developing a surgical practice. A surgeon starting a practice depends on his ability to communicate with referring physicians, gain their confidence, and when given the opportunity, establish strong relationships with patients who provide a source of positive feedback to the referring physicians. And I think that this is pushing again at the idea of IR as a clinical practice. So what happened in the 1990s? CTA and MRA came in. So a lot of the early, when I was a fellow, we had to come in and do pulmonary angiograms in the night to rule out PE. We had to come in and do aortograms to rule out aortic injury. So a lot of diagnostic work went to mainly CTA. I mean, MRA, people were enthusiastic about it for a little while, and then kind of went away most of the time. Then what other things developed? Dialysis intervention, venous access, which we look at now as IR light almost, all the venous access work. There's such a big need that we don't want to do all of it, I think. But it's made a huge difference in people's lives and a huge difference in people getting the venous access they need efficiently and safely. So before IR started doing most of the venous access work with like central lines and stuff like that, and all with ultrasound guidance that fortunately now we've allowed other people to use and other people do use because it's so valuable. But to put in a central line, when I was a medical student and resident, you accepted a 15 to 20% pneumothorax rate because it was all being done with service landmarks. Now that's being heard of now. So imaging guidance and our role in developing safe venous access has been huge. The expansion of embolization techniques and indications, aortic interventions for both aneurysms, trauma, and dissections, covered stents that we use in the arterial and venous system, the expanding role of microcatheter systems and the huge range of different kind of microcatheter systems that we have, and new procedures were developed in the 1990s, specifically for new groups of patients that we, as IRs, viewed as this is a service line that we can develop. And so one of the first ones was UFE, and another one was management of complications of portal hypertension, the first demonstration of which was TIPS. This is my contribution to the scientific. I said earlier today I wasn't really a scientist. This is my contribution to the scientific literature. This is my only first author paper in radiology. So I was doing a gastrostomy tube on a little 3-year-old girl who was recovering from management of a neuroblastoma. And she had decided she wasn't gonna have any more procedures unless her doll, she watched her doll get the procedure first. So I brought her and her doll down. Who knows how much this cost, but this was me building a practice with a 3-year-old, right? So I brought her down to IR Suite with her doll. We prepped the doll, we draped the doll, we took out a G-tube, you know, blocking pigtail, old-fashioned G-tube, put the needle in, put the wire in, put the G-tube in, and then she was okay. So I think this was just a image. I don't even think there was, I don't know if there was a story, you guys could look it up. But anyway, this was my attempt at recruiting patients to interventional radiology. So the IR identity progressed in 1990s when our society, right, SIR, the JBIR was launched in 1990. And the annual meeting added scientific sessions in 1990. Before that, it had all been CME. In 1991, the ACGME accredits VIR fellowships, so program requirements for VIR fellowships. In 1992, those billing codes that we had submitted in 1989 actually got approved by the AMA CPT committee. In 1993, we had our first meeting in a convention center with 2,700 people. So that's pretty decent growth from the previous, from the number of 500 when we first let people join. In 1994, the ABMS approved a certificate of added qualification designation for interventional radiology. So that, again, that's external recognition. That's not just us saying that we're something special. That's the ABMS saying we're external people, all 24 boards. And in 1995, the ABR launched the CAQ exam, so that there was a formal process. You do an accredited fellowship, you're a diagnostic radiologist, you do an accredited fellowship, you take the exam, you pass the exam, you get the certificate that is recognized by all the medical boards. In 1996, the SIR Foundation, which was called CIRREF at the time, again, too long a name, right? It launched its research grant program. And so the 1990s were really what I think people thought of at the time as a real golden age. There were lots of procedures, lots of new things. It was a very dynamic and exciting time to work in the field. There was minimal competition. Other specialties hadn't caught on. And we had a positive growing specialty identity that was now being recognized by external organizations. And there was really little clinical care. And again, I think the main reason for that is that nobody was hungry. So this is Gary Becker at his daughter lecture in 1999 at the SIR meeting. Now, a decade later, full-fledged clinical IR services are unusual, and most of our members do not admit patients on a regular basis or see patients in a physician's office environment. For overall commitment to clinical VIR, I give us a C-. So in 2000s, I would say we had a catalyst for change. And this was a time, I would say, when the world of interventional radiology was ready to listen to the visionary people who said a specialty depends on having a patient access, right? So the catalyst for change were that really other specialties, vascular surgery, cardiothoracic surgery, and cardiology, all developed a need and a desire and political pressure and education to learn how to do endovascular procedures, basically. And this provided the catalyst that I think really made interventional radiology take notice, because now people were going to get hungry, right? So this article by Barlacher and Ash in 2004 says, whether interventional radiologists are to become clinicians in the future is a decision the field must make now. And I believe that this is the time when we made that decision. So I would say in the 2000s, because of this competition and threat, we became energized. In 2000, the ACR approved the SCVIR resolution in support of clinical patient management in IR. In 2000, the SIR included clinical practice in the strategic plan, in emphasizing its importance. In 2001, ACR recognized IR as a specialty distinct from diagnostic radiology. And in 2002, SIR changed its name from the Society of Cardiovascular and Interventional Radiology to the Society of Interventional Radiology. And I put that in red because it was a controversial decision at the time, because there were people who said, well, if the cardiovascular isn't part of the title, then people will say we have no right to have anything to do with the heart and blood vessels. And I'd say the compelling reason to change had to do with the fact that nobody could say the name in one breath, and that we were all defined by other people as interventional radiologists. So it just made more sense to have a name and an abbreviation that was understandable and people could remember, and could be put on a logo without having to use abbreviations. In 2005, we developed the IR Primary Certificate Task Force at the SIR. In 2006, the first proposal for IR as a unique specialty was submitted to the ABMS. This first proposal did not pass, and in part it didn't pass because it viewed IR as being completely separate from diagnostic radiology, and it had components of it where the expectation of the interventional radiology world was that other specialists were going to teach us how to do our jobs. And so that didn't fly, but at least progress, tangible progress was being made. What happened clinically during that time? Well, we've got development of local regional cancer therapy, lymphatic interventions, and here's Dr. Cope again, who really pioneered the concept of percutaneous access to the thoracic duct. Complex embolization procedures, we could get more complex and do more things because of advances in embolic agents and catheters. Venous reconstruction of chronic occlusions became increasingly common and really provided care for patients. Vertebroplasty, kyphoplasty, other pain management procedures came online. And I think most importantly, people really started doing clinic and consults and rounds. So that clinical practice has become more and more, during the 2000s, I guess I should say, a real part of interventional radiology and an expectation from other specialties. So what's happened after that? And in the 2010s up to currently? Well, I think we've had expansion of our clinical and procedural domains, more in kind of a service line model, and more interdisciplinary work where we clearly have leadership roles. And I think the PERT teams, trauma teams, tumor boards, we are clinical equivalents of other specialties now. And I'm sure there's other things that you can think of, but these have all been developed in kind of concert with the clinical practice of interventional radiology, so that now we're just more, I would say, established alongside other primary specialties as a full service domain, you know. So what has happened also in the 2010s, I want to emphasize, is that in addition to growing, I would say, clinical expertise and technology expertise, we've also really ramped up our presence in the scientific world. And the obvious example of that is the ATTRACT trial, which was the first NIH randomized controlled trial led by an interventional radiologist. And I think it's important to recognize the role of Zeev Haskell here and the growth of the importance of JVIR as the scientific journal that is dominant in the world representing interventional radiology. So what happened? How did all this? So now we've got a real identity. We've got a clinical practice. We're recognized by the external world as being a unique domain. What happened? Well, the next time that interventional radiology and the ABR brought the concept of a primary certificate to ABMS, I think was in 2009. And in 2012, ABMS approved a primary certificate in IR/DR, interventional radiology/diagnostic radiology, as being a unique domain of expertise, separate from every other specialty. And they approved the certificate in 2012. ACGME approved the program requirements in 2014, and in 2016, we had our first presence in the NRMP main match. And the components of interventional radiology that make it unique are the imaging component, the procedural component, and the clinical component. And those are the three pillars of interventional radiology as a primary specialty. So how's the residency been? For those of you, we made it a little complicated. So this was the original training path. This was the original training path. You did an internship, you did 4 years of diagnostic radiology, you did 1 year of fellowship, and then you finished training in 6 years, right? Well, that's all gone away. And so now you can do the integrated residency, where you can match from medical school, although in the early years, some people just transferred from diagnostic into interventional so that we could fill our senior years while the first match was going on. And you do 3 years of diagnostic radiology, 2 years of interventional radiology that in the program requirements has to meet some diagnostic program requirements. So in those last 2 years, you got to do nukes, you got to do mammo. Most people make you do ER just so that the diagnostic radiology residents, because a lot of people funded these integrated programs by switching slots from diagnostic radiology to interventional radiology, so they didn't have to find more money. I think you guys found more money. That's good. So anyway, this is the 6-year program. And then if people decide late, they said, well, you can do 4 years of diagnostic radiology and then do 2 years of interventional radiology, so you finish in 7 years. And then in order to minimize the need to have 7 years of training, they have the ESIR, early specialization in interventional radiology, where a diagnostic radiology resident can basically concentrate in interventional radiology, or at least some of that training. Most of it concentrates after the core exam in the 4th year, and then matriculate into an IR independent residency with advanced placement so that they can graduate in 1 year instead of 2 years. So again, it's cut back to 6 years. So how's this all gone? It's gone very well. So this chart, I'm going to use this other, this is driving me nuts, you're right. Okay, so this is the 2016 match. We only had 15 programs in it, under 15 positions, so there were like 7 or 8 programs. And then this light green is the number of applicants, okay? So basically, and this blue column here is the number of positions offered, and then the gray column is the number of matches each year. So basically, as programs got accredited, you know, they got spots. I don't know why we went down. I don't quite know why this went down. The applications people were unrealistic. Right, I mean, there's only 125 spots, and we had 568 people apply, which means there's a lot of interest, right? There's a lot of curb appeal to interventional radiology. And then I would say by 2020, the expectations started to get more realistic, so the number of applicants went down. And then post-COVID, because everybody's applying everywhere for everything, the number of applicants has gone back up. But the match rate, basically, we had in 2022 in the main match, there were 169 positions offered, and we matched all 169. So it's been very popular and it's competitive, and I think it's a healthy option for medical students. So what's happened though in the independent residency? So the independent residency, which is the, you know, I'd say the do-over of the old fellowship model, but making sure that people get more than just 1 year of interventional, is programs want the independent model because it doesn't cost the institution as much money, because you're only paying for 1 or 2 years of a person, not 6 years, right? So people initially said, well, we were only gonna have our independent program until our integrated fills up, right? And so it's had, in 2019, so this was the first match, so these people matriculated in 2020, right? The 2019 match enters the independent program in 2020. So we had 202 people apply, so you got less interest because the people skewing into diagnostic radiology, there's probably fewer of them that want to do IR because people who want to do IR can say so straight out of medical school. And then we had 176 people for 150 positions and filled 141. The rest of them filled in the so they all filled up ultimately. Then you had 167 people, so applied for 166 positions and filled 154, but probably filled them all, the rest of them in the so. And now look what's happened in this spring. So we had 127 people apply for 182 positions. All of a sudden, over this year, people thought that the independent numbers were going to go down. The number of positions available would go down because they'd fill them in with integrated residents, right? But the number that people are asking for has gone up, and the interest has gone down. And we only filled 125 through the match of 182 offered. So what does this number mean? Well, I think it means I don't have any data. I'm sure APDIR is working on this, but what I think it may mean is that the overall amount of work being done, the educational opportunities in interventional radiology divisions over this period of time has continued to grow. And the least expensive way to have trainees to do some of that work is through the independent program, not the integrated program. And that people have some trouble funding the integrated program. So I think it will be interesting to see over the next, oh, wait a minute, what am I doing? Got the wrong button. It'll be interesting to see over the next couple of years what the world of interventional radiology does about this. Because there could be another thing going on where there are so many people, right? Let me go back. Can I go back? Yes. There are so many people. I got too many things here. I'm too old to have two things. I'm too old for two remotes. There's my laugh. So, what's happening to all these people, right? So, are these people not going into diagnostic radiology knowing that they could get an independent spot later? Are these people going into diagnostic radiology and then changing their minds? Are these people applying to interventional radiology, but they really wanted to get into ENT, so they matched the ENT? I think we don't know yet, right? The interesting thing, and this is a little bit of, the interesting thing, and the reason that I am kind of leaning towards the idea that there's more work to do, but we need to figure out how to recruit better into the diagnostic radiology program to fill that need. So if you look at we used to, if you look at the old numbers for the fellowship, so in the fellowship, these are the dark days. Remember when I said the odds were when we were being challenged, right? And we were kind of, what's going on? We had, 188 fellowship positions in the match, had 89 applicants and filled 75 spots, right? So, and then, we get to the 2010s, we're establishing ourselves as a clinical specialty. The mood is high, everything's great. The fellowship application, so here in the 2014 fellowship match, we had 275 applications for 227 spots and filled 219. And then, it dips down a little bit, comes back up, and it's coming down because some of these people are starting to offer fewer spots because they've got integrated people who are transferring from diagnostic to interventional. But if you look back at these kind of years, on average, we were putting out, like I'd say 200, 210, 215 fellows a year were entering the workforce, right? So now let's go forward. So if you look at the 2016, no, that's not what I want you to look at. Oh, yeah, this is too complicated. No, what am I doing? So I'm not going to show you the numbers. You got to trust me. If you look at the number of people who matched in the integrated program in 2017, they're going to finish in the 2023 because they matched in 2017. They're going to finish in there. If you add those numbers to the number of independent residents who just matched, we're putting out about 220 people a year still. So what we're putting out into the workforce is about the same, and that's why I think that some of this is increased work and departments wanting to have more trainees. You know, but I think to fill those positions, we need to change our strategy in how to attract the students that don't match into the integrated program. And I think that needs to be a focus of APDIR. Okay, that's all the math I can do. All right. So I think our residency and our identity, which now is really cemented, right, is a disruptive force in the world of radiology in general. And so this is where I'm becoming philosophical. I do think that there's evolutionary optimism at this point in time. We have a clearly defined identity and domain and educational program and workforce that is very enthusiastic. And I think that the interventional radiologists trained in this new residency model have a new model of IR practice as a driver of clinical care and image-guided procedural care. And it's a totally different mindset than people who would have come out of the old system, especially before clinical IR became a focus in the 2010s. And don't forget, people running radiology groups mostly trained before all this happened. And I think another thing that we haven't talked about much, but another thing to be very optimistic about is that the physicians in all the other specialties are now coming out of training, expecting to work in an IR with IR colleagues who trained in the model that they had at their training program and who anticipate having a clinical practice. And to have, you know, interdisciplinary collegial activities kind of on an equal plane. So I think that we expect it, and I think that other specialties now expect it, but I think it's a fundamentally disruptive thing. So there are some challenges just in the relationship between IR and DR. So radiology, diagnostic radiology, private practice business models are an evolution. I mean, there's a lot of traditional radiology groups. There's huge non-physician owned corporate owners. There's multi-state physician groups, very large. There's people now working as hospital employees. And I think that teleradiology has also become a disruptive force and it's been accelerated by COVID, right? So the advantage of teleradiology is that it has allowed some of these large multi-state physician groups and corporate groups to provide subspecialty image interpretation 24/7, no matter where those images are coming from. But the disadvantage of a lot of these models is that it limits access to image-guided procedural care in underserved or rural locations that were previously served by generalists who did some diagnostic radiology and some kind of IR light. And I think that our residency and our identity has not been the only force, but has contributed to this issue. There's business models, and in part because of some of these business models in private practice and diagnostic radiology, there's an evolution going on in business models in IR. So there's still traditional private groups where you have IR and DR and people are all doing kind of part-time. There's solo IR practice, which I think is a very vintage practice model. There's group IR practices. Chicago has one very large IR group that serves the IR needs of a large number of hospitals and has their own office centrally. There's multidisciplinary practices where you've got IRs and vascular surgeons and cardiothoracic surgeons all working together. And again, you have IRs who are acting as hospital employees. And our clinical base is an evolution, which has traditionally been hospital-based, but now with some of these new work models in IR, there's a real tension between independent interventional radiology practice and the whole diagnostic radiology exclusive contract system. So that's an issue. And then there's issues where office-based IRs are having trouble. They say they need to be able to admit patients, and then they get into difficulties with exclusive contracts. So there's a lot of challenges in our evolution of how to practice, right? And in diagnostic radiology and interventional radiology. And then concurrent with all this, there has been an academic practice model evolution that you have all experienced, which is that training programs, departments in radiology, and the ABR certification process really emphasize subspecialization, where for your final certification exam in diagnostic radiology, you can choose, you have an essentials module, but you can choose what parts of radiology you want to have on that exam because you had a comprehensive exam earlier in your education. And then what's happening in some hospitals, and it doesn't seem like it's happened here yet, but in many academic programs, basic image-guided procedures, which used to be taken care of in other divisions, are being pushed to interventional radiology. And some of that, I think, provides better patient care because we have the whole system of the pre-procedure holding area and the post-procedure holding area and the nurses and sedation and monitoring, and it's all very seamless because we do it all the time. And sometimes it's hard in some departments to get sedation for procedure in CT because they aren't used to having the nurse there and barriers. But in our department, we're getting pushed to do more of these general image-guided procedures that I view should remain as a crossover between diagnostic radiology and interventional radiology. And some of this has been, I would say, it is happening for two reasons. One, because you can make money so much faster reading CTs, and because there's such demand clinically for fast turnaround times with diagnostic studies, that it's very disruptive to the diagnostic radiologist's day to stop and do a procedure. And then the other thing is COVID, where radiology, diagnostic radiology, is one of the few medical specialties where during COVID, you could do all your work as a diagnostic radiologist from home. And so this is an issue, I think, that is strengthening the subspecialization and the idea that all procedures have to be done by an interventional radiologist. Because I don't think that was what we thought was going to happen when the specialty was really being developed. And in my department, and I don't think I'm alone, I've talked to some other people, you have increasingly non-IR division faculty are uncomfortable doing procedures, right? And IR faculty, like I just said, are becoming increasingly responsible for all IR and DR resident procedural education, right? And I think that diagnostic radiology residency graduates will adopt the practice domain model provided by their GME programs, so that the stress of division between who's doing procedures in the general world and who's doing procedures in academic, in the academic model is going to get more pronounced. Did I say that in a way that makes sense? I got the wrong remote again. And why I think this is important from an access to care issue is that if you look at it, Duzak, is he the ACR president now?
He's chair, Mississippi.
Oh, he's the chair of Mississippi, but he ran the Neiman Institute, right?
Policy Institute.
Yeah, he ran the Neiman Institute at the ACR, and he's done a lot of kind of deep data diving. And a paper that I think he was a senior author on in radiology demonstrates that of the 25 most common image-guided procedures billed by radiologists, this was in 2015. Third of the 25 most common ones, almost all of them were what would be called lower middle level procedures by their RVU designation. 13 of those 25, the majority of them were performed by radiologists in private practice who were, by how they billed, could be considered generalists. So they built such a wide range of CPT codes in the radiology domain that you couldn't say they were any kind of a specialist. So that in the low-level procedures, 46% of them were done by generalists, and this is all the blue stuff. Red is interventional radiology, and green is other subspecialties. So like breast imaging, neuroimaging, MSK. Mid-complexity procedures, which includes paracentesis, PICC line placement, a third of them were done by generalists. And the reason these don't look right is because I screwed up when I changed the. And then the high-end stuff, 23% was still done by generalists, so you can see the vast majority of the high-end stuff, RVUs over 4, I think, were done by interventional radiologists. But these procedures are done far less commonly, and the numbers here are too small for you to read, but these procedures are done far less commonly than the mid-level and low-level procedures. So that if in training programs, we are emphasizing that people should subspecialize and that basic procedures are not part of diagnostic radiology, that is going to affect access to care. So that's okay. So I think that generalist care and the idea that some basic procedures are in the domain of diagnostic radiology will ensure access to care, even though specialty care probably in most cases elevates the quality of that care. And right now, around 2018, when they wrote this paper, there's like 3,000 counties in the US. And generalists who did a lot of those common procedures are present in 869 of those counties in the year that they looked. And interventional radiologists are only present in 347. And probably some of that has to do with our emphasis on the high-end work that we all want to do that is keeping us busier and busier and busier. But you can't do that in a small hospital in rural Virginia. You need to be at a big center. And so I think that as we move forward, we need to figure out how to make sure that we're putting out enough people who are going to be able to do the work that the patients in the United States need. So my questions for all of you guys to figure out as you embark on your careers is how will patients in rural and suburban health systems access IR care if all of the IR care is remote and procedural skills shift completely to IR? Will we have IR hospitalists who do that kind of stuff? Or will other specialties step in? And that probably happens in some rural areas right now. How will hospitals negotiate with practitioner businesses to assure that they have both IR and DR services? And can IR and DR navigate a path that keeps patient needs at the center of all our decisions and our conversations? Whoops. So I think that we need to have a lot of conversations in the next few years that involve a lot of important organizations. And I think that two key ones, not just the accreditation, I think the accreditation and the ABR will be influenced by what the ACR and the IR and SAR world work together to make progress on this. So, final quote, it is not the strongest and the most intelligent who will survive, but those who can best manage change. And here I found this quote by Alan Matsumoto, while often uncertain and uncomfortable, and I think a lot of these issues I'm kind of talking about here are uncomfortable, change can also be exciting. And I think that it's up to us to move our specialty forward in a way that meets the needs of the patient population of the US, and that means that we all have to pay attention to the basic image guided procedures as well as the high-end stuff that can really move care forward in ways it hasn't seen. So thank you very much. I'm sorry I went over time.
Questions for Victor?
Thank you, that was wonderful. I'm actually a vascular medicine doctor. I'm not a radiologist, but this was great to hear because, we are at the infancy probably of where we are in our specialty, and it's sort of nice to see how you guys have changed. So I have two questions, one from a historical perspective and one from a future aspect of it. From an historical perspective, I saw how you were looking at all these different procedures and everything. Coronary interventions, that's an area that, I see that IR didn't ever get involved in, and I'm seeing right in the beginning, you work with Andreas Grunze, who really, I think he pioneered coronary interventions aspect. So what happened? Do you know what happened at that stage that was sort of isolated or different?
I think I'm not quite that old. I think that cardiologists own the heart so much that just kept going. I know that when I was a medical student at Ohio State, it wasn't the Ohio State back then, it was Ohio State. The person who inspired me to go into IR before it was IR was a radiologist, and he did the coronary angiograms for one of the cardiothoracic surgeons. And then that guy retired, and then all the coronary angiograms went to cardiology. But my guess is it had to do with the fact that they just owned the heart to begin on.
The other thing was I was wondering, I often see this, there's so much robotics and AI now. And I hear about these, scenarios where you're having somebody sitting in San Diego doing a complex intervention on someone in Montana. And of course, they have backup people, but perhaps it's too complex for the person locally to do it. You're talking about the evolution. Do you see something like that potentially happening?
Well, the first iteration of the remote access, I actually trained on, where you weren't in a different state, you were operating joysticks in the control room. It was very cumbersome, but the first iteration of anything new was very cumbersome, and that company went under. But I think there's other things in development, but I open it up to other people who may know more about the field of remote intervention. Yeah.
So to your first question, in the 60s and 70s, radiologists often did perform and interpret the cardiac caths. Little by little, as radiology technology grew, ultrasound, CT, MR, radiologists tended to move towards that, and cardiologists gravitated more towards cardiac. So probably around the 80s, right around the 70s and 80s, there was a shift in the cardiologists doing their own casts and reading them all. But while I was a resident, we read out all the cardiac casts. That was in the 80s, but it quickly changed. In terms of remote, there's a device called Corindus. Siemens owns it. I envision that probably within about a decade, we'll be looking at how to do remote interventions for stroke, particularly if you can do stroke, because we know you lose a lot of time, you lose brain. And I think there's a heavy drive by imaging industry to do that. And I think there are a lot of stroke interventionalists that would like to be able to do a hub and spoke technique. So I think probably in a decade or so, we'll start seeing some of that deployed and trials going out. So, and to Vicky's point about small rural practices, for radiology, that represents 30% of our business in the United States. Really, and that's communities less than 200,000. That's 30%. That's 30% of the population of the United States. And so there's a paper that's coming out in JACR shortly, talking about how ideas about how to potentially manage that conundrum between small and general practices, and having an IR in a private practice group of 5 or 6 people don't have enough business, or nor can they afford to pay an IR, nor will IR want to go work there if they can't make a living and do what they want to do, and they're forced to read plain films and take diagnostic call plus IR call every night. So it is a problem that we're going to have to address. To Vicky's point about access, that's a lot of patients that we have to think about. And so I think, and then Vicky made a comment that we got more money here, and that's why actually what happened. The ABR approved a pathway that we can match from 99 2000, and you could take medical students straight from medical school. So we went to our DIO and told them that interventional radiology is very different, because our practice was, we were already admitting patients in 91, we were doing consults, we had clinics at that time, and he recognized that. So he had seen us up on the rounds and things like that. He's a pediatric intensivist. And so when I went to him for that proposal, he approved it. And so we started in 2001, the VIR pathway direct out of medical school, which basically is
the integrated, yeah,
pathway.
yeah.
So we just transitioned our VIR residents to the integrated pathway. That's what we're.
Oh.
So we already had them mixed, sort of 2 to 8 of our 10 residents
Yeah.
in our residency.
Yeah.
That's how we did it. It wasn't, we got money earlier on.
Yeah, you got the money sooner.
Anyway, so other questions for Vicky? I mean, she's introduced a lot of interesting thoughts and concepts. You know, these large venture capitalists, private equity groups are changing radiology as well. They're starting to run into some issues financially because they extract money out of the system. And to your point about SIR and ACR trying to figure some of the stuff out, that with the transitioning of leadership in the college, there's going to be a tighter relationship between SIR and ACR. I think we'll see that coming through.
Awesome.
Yeah, so,
Thank you.
yeah. Other questions for?
Yes, sir.
Thank you for the great question. That's very lecture. I'm Dr. Torikai from Tokyo, Japan. So I'd like to ask you a question. So if you have any opinion, could you tell me what you hope from foreign interventional radiologists to develop IR in the United States?
You need to train here?
Training or education, just general IR development. So I think I want to actually I want to get a broad certification in the US. So do I what to say? Am I a good option to fill the shortage of IR in the United States?
To,
A shortage of the workforce. So
you mean, should you, I'm confused.
So
I think I'm tired.
So I think to restate your question, I think you're asking, is there a way for someone like yourself in Japan, who's a trained interventional radiologist, to become a certified interventional radiologist in the US to help solve some of the shortages of IR in the United States?
There is an alternative pathway to certification in the ABR system to be certified as an interventional radiologist in the United States. And I don't have its details off the tip of my tongue, but it's on their website. It's on the ABR website, what that alternative path would be.
So we've talked about this, and that pathway from the ABR is an international medical graduate pathway. It's a 4-year pathway, and it's one of the few American boards that allow foreign or international medical graduates not to have to repeat the residency.
Yeah,
Like if you're a trained surgeon in Austria, you have to come here and do a surgical residency. Whereas this international medical pathway allows you to do maybe 4 fellowships in different areas and be able to qualify for the board over 4 years. Or even depending upon your situation, do 1 year of fellowship and potentially work for 3 years at that institution if they need you
As a faculty member.
as a faculty member that has an ACGME accredited residency to be able to then sit for the boards. But I think we and maybe ENT, there's only one other specialty boards that allow that to occur rather as an alternative pathway, rather than having to repeat a complete residency in that specialty. I think that's what you were asking, right? Any other questions or thoughts?
Okay.
All right.
Thank you.
Thank you very much. Before she leaves, I'd like to just give her presentation. So this is for you for
Oh my goodness.
being our 13th Tegtmeyer lecture. So,
Together there, with the slide in the back. Outstanding.
Thank you.
please feel free to open. We'll rewrap it and mail it to you.
Oh, okay. Well, you know, I have a big suitcase. It would probably
Yeah,
fit.
well, either way you want to do it.
I have to get bigger offers.
Yeah, get a bigger wall. too.
Oh, look at how cool. Awesome. Okay, so I've got a story about this. This is the rotunda. So I was given a tour of the campus today, and we went in the rotunda, we toured the rotunda room. They gave me a little booklet. I'm looking at the booklet. We're walking out of the museum. I'm looking down at the booklet, and I go bang into the glass door. I just didn't see it. So now I will always have that to remember.
That's a great way to close. That's Vicky. That's her laugh. So she'll be around. I think she's got the 7 a.m. duty tomorrow morning.
7?
And then 12 noon conference.
Yeah.
And then I think she's going to dinner with some folks tonight. So
Yeah.
that'll be great. So thank you very much.